Hello and welcome to Think Like a Clinician, question 92. A 24-year-old male presents with sudden onset, sharp chest pain and shortness of breath. On examination, there is decreased breath sounds and hyperresonance to percussion on the right side. So the question asks, what is the most likely diagnosis? A. Pleural effusion. B. Spontaneous pneumothorax. C. Lobar pneumonia. D. Pulmonary embolism. Now think about the case, provide your answer, and then we'll dive into the discussion. So this is a 24-year-old male presenting with sudden onset, sharp chest pain, shortness of breath with a clinical examination revealing decreased breath sounds and hyperresonance on the right side of the chest. So a young, previously healthy male patient present with acute onset pleuritic chest pain and dyspnea with a physical exam revealing a hollow chest on the right side given by the hyperresonance to percussion and the absent breath sounds. We have not been told of any history of trauma. So this is a male patient, a sudden chest pain, hyperresonance, which point directly to the air in the pleural space. Now let's try to understand the physics behind all of this. Normally, the pleural space has negative pressure. A rupture in the lung parenchyma, oftenly a subpleural bleb, allows air to rush into the pleural space, causing the lung to collapse. Now, the percussion that was being talked about. Air is less dense than lung tissue. So when you tap on a bag of air, that is in the case, for example, of a pneumothorax, it sounds hyperresonant, like a drum. When you beat on a drum, the sound you hear, that is what you would hear on a pneumothorax. Unlike the dullness of fluid or the resonance of a very healthy lung. So from this, of course, the answer is B, spontaneous pneumothorax. So why not tension pneumothorax? So while our case here points at pneumothorax, a tension pneumothorax is often a clinical diagnosis of shock, maybe in the case of hypertension with tracheal deviation, with some jugulovenous distension. This patient is stable for now, okay? And why not pneumonia? Pneumonia presents with fever, a productive cough, and dullness to percussion, often signifying the aspect of consolidation and not hyperresonance. So why not pleural effusion in this case? Perhaps you might ask yourself. Effusion is fluid. Fluid is dense and yields a stony dull percussion note when you do a percussion on the chest, of course. So in this case, something maybe you can pick or something you can learn is that the tracheal shift rule. In a simple pneumothorax, the trachea remains midline, okay? If the trachea shifts away from the affected side and the BP drops, it has progressed to a tension pneumothorax, which is a surgical emergency requiring immediate needle decompression. We'll talk about that in a future video. But as you can see also from the chest X-ray that is on your screen right now, that is a depiction of a spontaneous pneumothorax of the right side of the lung, and you can see the trachea is still in the middle. Thank you for joining us today. I will see you in the next one.